Hi everyone, my name is Dr. Ryan Robinson, and I am a general dentist, and I specialize in helping people breathe. We are here today with Howard on his journey to find out what's going on with his airway, and it's really a team approach that we use here in my center called the Pain and Sleep Therapy Center. And what we do here is we have a team of experts who have very advanced education and awareness of sort of a lot of the problems that plague individuals from a breathing perspective, from a pain perspective, and a quality of life perspective that is really deep-rooted into the airway. And so it's a journey that we take with a lot of our patients, and we discover sort of the root causes of their problems, and we try and pull that out and create treatment plans that include a lot of different specialists in our area, around the world. And so our goal here is to help our patients restore their quality of life, get their breathing under control, understand how to live a healthier, happier life. And so it's something that I'm very passionate about. I've kind of stopped doing general dentistry a couple of years back, and I haven't looked back since. I feel like I can make a much bigger impact, a much bigger influence on my patients if I'm able to sort of discover the root causes of their problems and not just drill in their teeth. So happy to have anybody out here, and happy to be working with Howard today. Yeah.
Okay.
So Howard, the first thing that I'm seeing when I look inside your mouth is I see dental arches, I see jaw bones that are really, really narrow and really, really small. So typically what we should see is we should see a maxilla, the upper jaw, being bigger than the lower jaw. So naturally our jaws want to be like this. So during development, when we're kids, our upper jaws grow downwards and they grow forwards. And every single time our upper jaws grow, our lower jaw will respond to that by growing more, right? And catching up. That's typically how it goes. The maxilla, the upper jaw, grows first, the mandible catches up. And remember, that mandible is just a floating bone. So it's only muscles and ligaments that keep that bone from falling off your head. But the maxilla is the part of the cranial structure that does not move. So we need to get good craniofacial development, good maxilla development in order to have mandible development. So it looks like from a development perspective, your upper jaw is really super narrow. So what we see here is we see a crossbite, not just on one side, but both sides. So if we see that in our youth today.
So what's a crossbite?
A crossbite is when the upper teeth are actually on the wrong side of the lower teeth. So you can see your upper teeth are inside of your lower teeth, your upper teeth are inside of your lower teeth. So like I was saying, naturally that upper jaw wants to be bigger, and the lower jaw should accommodate to that and catch up to its growth. So it looks like you've just had such lack of development within your upper jaw that lower jaw is actually bigger. And so like I was saying, remember, the roof of the mouth is the floor of the nose. So small upper jaw, small nasal complex. Okay? Dana, can you go?
Sure.
Can you move through the slides here with me? Okay, that's a good shot. Keep going. And then you can just see your bite. So your upper jaw, or your lower jaw, the molar tooth back here is actually in front of the molar tooth on the upper, and that just means that that lower jaw is a little bit more forward than the upper jaw. Again, very mid-facial upper jaw, very deficient. You even have some recession and some root exposure that we see here. And root exposure and recession, a lot of people and a lot of dentists think it's just from brushing too hard. Most of the time, if we have a person who has a problem breathing, and we have a person who grinds their teeth because they have a problem breathing, that grinding puts so much tension and pressure on the teeth that the actual foundation of the teeth, the jawbone, will start to break down, will start to resorb, and then we get the pullback of these gums, we can get this root exposure, we can get teeth that are compromised and are more susceptible to disease and potentially loosening as you get older.
So why am I grinding if I'm having trouble breathing?
Yeah, so that's a great question. So we now know through the research that there's only a couple of reasons why people grind. A lot of people blame it on stress, and I would agree that stress is a big part of grinding, but most of the research supports the fact that most stress, the biggest stress in life that can happen, is the stress of not breathing. So the brain is very protective. The brain always wants to fight. The brain's natural sort of response is keep the person breathing at whatever cost. It'll sacrifice everything in order to keep the person breathing. So what we find is a lot of people that breathe, when we put them through sleep studies, we realize that their airways collapse. We realize that they have a cutoff of oxygen, or they have a decreased air supply to their body. Their brain registers that as an attack. Their brain's only physiologic response without waking you up from sleep is to grind the jaws and thrust the tongue forward. So the more likely the jaws are to thrust and grind against each other, and the teeth sort of work by taking the lower jaw and like pushing it forward, grinding, pushing the tongue forward. All of these little signs that happen in the middle of sleep are all sort of protective measures to keep your airway open, because if you know the anatomy, in which we'll go into, the back of the airway is the cervical spine. It's the neck, the part of the spinal cord, that's the cervical part. The beginning of the airway is the upper and lower jaw. So in between those is the muscular tube called your airway, and so that typically is the part of the airway that will collapse, and that's the part that has the flexibility to get bigger or smaller according to how well you're breathing. And so when we see that grinding, we automatically think, and dentists like me automatically think, is this person breathing properly at nighttime? So that's what I see going on with you. Keep rolling, Dana. Same thing on the left side. He even has an open bite, which looks like where his tongue sits. So typically, and this is a cool concept, Howard, so I want to make sure I kind of go over this real quick. So most teeth will come in until they touch something. Now, most of the time, teeth will touch each other, and then they'll stop. That's kind of their position where they balance each other out. When we see something like this going on, where most of your teeth are touching, but this one molar and this other molar, they just stop short, like something held them up. So I have noticed that for you, your tongue appears to be big. I would even say your tongue might look like a 6-foot tiger in a 3-foot cage, right? So your tongue looks a little bit big for your jaws, and it is. Your tongue is normal size, your jaws are small, remember. I think your tongue is fighting for position throughout the whole entire night, probably throughout the day as well, to just get out of the airway and get kind of into the mouth where it should be. Now, if the tongue has certain predisposition to taking up space, we now know that that's probably a spot that if we were to have a laser sort of beam that goes through your face and we get to check where your tongue is at all times, it probably hangs out there a whole lot. And that's probably where your tongue is.
This is like the garage door won't close all the way because there's a tennis ball and it thinks that's the floor.
Yeah. Oh, perfect. I love that.
I
love that. Yeah. I'm a big analogy guy, so I love that because I think it's exactly right, and I think a lot of people don't understand how powerful the tongue is. The tongue is composed of 16 muscles, 8 on each side. It is considered the strongest muscle in the whole entire body. And the tongue can exert 500 grams of pressure onto teeth, onto the different structures. That's why having the tongue up in the roof of the mouth when you're growing and developing as a kid is so important, because it drives growth of the jaws. Now, if you have a low tongue position for whatever reason, you're going to have a lack of development. So for you, your tongue likes to hang out in between your teeth, and I don't care what orthodontist you go to. An orthodontist can take some brackets and try and close these teeth up, but if you don't wear a retainer or you don't block your tongue from getting back in there, that tongue is way more powerful than any sort of braces that
So I did have retainers.
Did you?
For many years.
You wore them?
I wore them. I also remember like searching in a dumpster. Like I didn't like. I take it out for like cafeteria lunches and. Yeah, Mom's like, I spent $500 on that thing. You better find it. Yeah, absolutely. So retainers are kind of an orthodontist way to ensure that anything that they did doesn't get reversed. Now, if our tongue and our lips are working properly, think of it like this. The tongue is the body's natural expander. The tongue is the body's natural retainer. And when the tongue and the lips and the teeth are all in balance, there's nowhere for those teeth to go. If there's good development of the jaws, if the tongue's doing what it's supposed to, if the lips are doing what it's supposed to, the cheeks are doing what it's supposed to, the teeth are going to stay put. And so it's no mystery. People that don't need retainers and their teeth stay straight, they have good balance. They have good growth. People that they take the retainer out for 3 nights and the teeth start to go back, it's because it's an unstable environment. And so I like retainers in the fact that it keeps people's teeth straight, but I know if I take a retainer out and the teeth start to go wonky again, that means the system's not in balance, and that's a big problem long term. What else you have? Okay, cool. Keep going. So yeah, your tongue, a little bit of scalping, a little bit of coating on the tongue. And so the scalping of the tongue, which is basically sort of these irregular borders, just tells me that your tongue is kind of thrusting into your teeth a lot. So a lot of times we'll see our patients who have these little ridges on the sides of their tongue, and that means that the more that the tongue is thrusting forward at nighttime, the more likely it is to start taking the shape of the teeth. Again, another sign of breathing problem. And actually the research shows us that tongue scalping is actually 79% predictive of a sleep-related breathing disorder, which is cool. So as a dentist, knowing nothing and maybe just attending one of my classes, if I look in my patient's mouth and I see tongue scalping, how are you breathing at nighttime? That's immediately the first question that I ask.
Dentists have never asked me that.
Maybe it's perhaps they don't know or they haven't been educated yet. Unfortunately, our dental school and our medical school curriculums are a little bit behind. As you probably know, we're probably practicing medicine and dentistry that was relevant 30 years ago and probably hasn't caught up with the times. Just as a historical perspective, sleep apnea was founded in 1979 by Dr. Colin Sullivan. So 1979 was the inception of sleep apnea, and when people really started focusing on breathing. 1982, we got a CPAP, a reverse vacuum machine that would blow things down. All of this stuff is relatively new as far as humanity goes. So we're looking at breathing a whole lot more. I mean, I just think it's a whole lot more prevalent these days, but a lot of dentists they weren't educated on this stuff. I wasn't educated on this stuff, and I consider myself rather young. I was in dental school 10 years ago, and 10 years ago, we didn't have one class on breathing. We didn't have one class on what all this stuff meant inside the mouth, because I don't think people knew. This is a relatively progressive sort of educational level that we're at now. Go ahead. Yes, can you flip that? Can you just spin that for me? Beautiful. So, Howard, one of the things that I'm seeing is when I look inside your jaws,
This is the
upper jaw.
Roof of the mouth.
Yep, this is the roof of the mouth. What I notice is your teeth are straight, fantastic, but you're missing a bunch of them. You're missing one over here, one back here, and one back here. You're missing 4 teeth in the grand scheme of things. And it's because the jaws are so narrow. You can see your vault, your palate is very high. So you have more of a Gothic arch instead of the big, broad Roman arch. The bigger, broad Roman arches means that the bones develop properly. It means that all the teeth can fit in. And also remember, it means that we have a bigger inside of our nose. We have more ability to breathe properly just because we have better space. Can you continue on?
This is going to have a happy ending, right? Because
Absolutely.
I'm pretty sad right now. I'm so broken.
No, you'll be. We're gonna figure this out. So can you spin that around a little bit?
You want me to turn it this way?
Yeah, if you don't mind. Okay. So here's a picture of the lower teeth. Again, kind of the same issues. The tongue is kind of stuck inside this very small space. In fact, it looks like, I'm sure your orthodontist, when you were a kid, didn't leave space here. So your tongue is pushing some of these teeth around a little bit. Again, it's a system that looks like it's unbalanced, and there's definitely some discrepancies going on. Dana, keep rolling.
Sorry.
Oh, you're good. I know you're pounding away over there
Yeah.
at all the notes that I'm saying. Tongue, actually, range of motion looks pretty decent.
Yeah, correct.
No restriction whatsoever. A lot of our patients have tongue ties, which means the tongue is actually tethered to the floor. People that have tongue ties are structurally restricted, and their tongues are more likely to fall in the back of the throat at nighttime. And if the tongue falls in the back of the throat, that's an immediate way to cut off breathing, and that's a big, big problem. So we see a lot of our patients, both kids and adults, that actually have tongue ties that need to be addressed.
So it's so interesting because when I had my first sleep study, I did talk to a specialist and got fitted for CPAP, and they were going through all the reasons that I could have sleep apnea, but no one evaluated any of them. It's like, well, this could be a problem, this could be a problem, and you can actually just like that test you did was like 4 seconds to determine, oh, not tongue tied, like that, like we can eliminate that.
Exactly. I mean, and that's what I think that's why you drove from North Carolina. Right?
Well, if there had been anybody else, I would have.
Yeah, absolutely. And I would have loved to help you out with somebody in your area. Unfortunately, people like our team here, it's a very comprehensive sort of approach that we have. That we made big sacrifices back in the day. That we weren't just going to be tooth mechanics anymore. We weren't just going to put crowns on people's teeth and fix problems that they had. We were going to go understand why. And so as you saw in the James Nestor book, Breathe, sometimes you have to go to the depths of the earth to figure out the true sort of whys behind things. And so some of us dentists were willing to do that, and some of us in the sleep medicine field were willing to do that. So it's really hard to find good providers who actually understand why this happens. In today's society, we're run by health insurances. Don't want to get into politics, but we're run by health insurances, and our doctors are sort of handcuffed in the way that they treat. So we practice the medicine of what typically and not why. What is it? How do we fix it right away? And CPAP is the easiest, sort of longest term thing that we've kind of come to know that can actually fix sleep apnea. And when I say fix it, I don't mean fix at all. That's the wrong word. A CPAP manages.
Yeah.
It just manages. It's a Band-Aid for a problem that probably is going on, not just at nighttime, but probably could have effects that can't be measured as well during the daytime as well. So yeah, I'm glad that you can kind of understand how comprehensive this is, because these little things that we can do can just give us way better paths forward and options to be able to treat this and potentially fix this. And I'll use the word fix now.
Right. I mean, that's, what the reason I'm up here, not just for myself, is so I'm really into lifestyle medicine, and I know lots of lifestyle medicine docs and practices, and this feels like it's like breathing is a totally orphan field.
Yeah.
Like we don't, we talk about nutrition, exercise, stress, social support, sleep, and right, breathing, like 20 times an hour, I stop, and that, like I don't. It's sad to me that it should be like dentists leading the field. Right, there should be a doctor of breathing.
There should be.
And then you'd be an adjunct, and then
there should be.
ENTs should be an adjunct.
Yeah, and so I'll get into it with you because I think it's a great conversation to have. But we have pulmonologists, and they're considered doctors of breathing. They're considered doctors of the airway. Now, unfortunately, a lot of pulmonologists, and I have great respect for pulmonologists, great respect, but unfortunately, pulmonologists know the system from here to here very, very well, right? Once the bottom of the throat hits the chest cavity and the lungs and the alveoli and the way that oxygen exchange happens down here in the lower part of the airway, pulmonologists are the experts at that, and we rely on them to tell us a whole lot of things about that, because it just doesn't start and stop right here. It starts and stops with the whole entire airway and how the body works with that airway. Now, the experts from here to here are two people, dentists and ENTs, right? But dentists have been taught to be tooth mechanics. They look at the teeth and they fix the teeth. ENTs have been taught to look for infections and clean out sinuses and take out tonsils, and nobody has been taught to kind of understand the way that the airway works. It's like all these different specialties, but nobody has the full kind of grasp of how it works. So I agree with you. If we could come up with a specialty that would focus on how the airway works and breathing in general, believe me, I'd be the first one to go get certified in that, because this is what I do and this is what I'm passionate about. Unfortunately, there's no specialty out there like that now. Any other questions on that? Okay. So keep rolling. He's got good range of motion with his jaws. He can open pretty wide, about 50 millimeters. Normal is about 45 to 60 millimeters. Keep rolling. Tongue to spot looks about like 35 millimeters. So when the tongue goes up to the roof of the mouth, we want to know how big can you open. And yours is pretty good. It's about 80%, which is what we're looking for. And as far as we always take this picture, this is a neat picture. We always take this picture because we want to look up people's noses and figure out, is there a structural problem right off the bat? Are we asymmetrical right off the bat? Do we have these big polyps in here? Do we have external nasal valve collapse right here? We want to know. So far, you're looking good. Okay. You're looking good. But we're going to figure out what's going on inside your nose once we take our CT scan. So keep going.
Okay, that's definitely my new profile picture.
Yeah?
Head tilt.
Little head tilt to the right. Yep, I agree. Little forward head posture. Yes, shoulder cant. Yeah. Yeah, I like that one. That should be your new profile picture. There you go. Okay, occlusal cant doesn't look bad.
Yep, you can see more of his left ear than his right ear.
Yeah, you definitely can. You can see definitely more of your left ear than your right ear, and that may be because of, again, the way that your cranial facial structures develop. All these cranial bones have to kind of develop sort of properly and symmetrically. And so whenever we see the ears that are hiding on one side or the other, we're always thinking, how did that temporal bone grow? Is that temporal bone kind of closed in? And is that something that we need to address through our treatments, getting that balanced out? So that may be working with a craniosacral therapist or something like that. So keep rolling. Okay, good. So, yeah, I mean, based off of what I've seen by doing the intraoral exam on you, based off of what I see from taking a very thorough history on you, I think what we need to do is understand exactly the structure that's going on and how your airway performs. So what we're going to do today is a series of tests called a CT scan, which is an image that goes from the tip of your nose all the way to the bottom of your throat. That's going to allow me to look at your nose, your sinuses. It's going to allow me to look at your jaw structure. It's going to allow me to look beyond your teeth at your airway. It's going to allow me to see and measure the size of your airway. It's also going to show me your jaw joints. I know we have a little bit of clicking on that one side. I want to make sure that those are healthy. The other thing that I want to do is I want to be able to do a pharyngometer to test his airway collapse. I want to be able to do motor nerve reflex testing to see if there's any other structural injuries going on. And then from there, come and get me and we'll review everything.
Sure.
Cool. Have fun with these girls.
All right.
All right.
Thank you.
So, Howard, the motor nerve reflex test that I just did is an orthopedic neurologic exam. It tells me if there's any structural injuries in your body. And so, guess what? You passed. So there isn't anything that we need to address from a structural standpoint. A lot of times in my treatment plans, I have patients that grind their teeth, that can't sleep well, that have breathing problems, and there's a lot of structural injuries going on around the whole entire body, whether it be an old sort of sports wound, or it be sports injury, or some sort of other kind of structural problem. A lot of times I'll use the expertise and sort of help and collaboration of like an osteopath or a functional medicine doctor, a regenerative doctor, a craniosacral therapist, things like that. So the good news for you is you passed that test, which is great.
All right.
So what else did you find out about him?
As far as the pharyngometer, his initial baseline 2.92 as far as his minimum.
Wow,
and by
that's not bad.
increasing his vertical and keeping him edge to edge, he maintains with collapse.
Okay, great. All right, awesome. So the pharyngometer that they did, was that pretty neat?
Yeah.
Did you like that?
Mm-hmm.
So it basically just like maps your airway through how much space is there, and it tells me what happens if we were to take away all of the air in your airway. What then happens? Do you collapse, and does your airway get smaller, or does it remain the same size? So it tests the collapsibility of your airway. So it looks like your airway collapses.
So it's like I have like garden hoses that are rigid, and then I have other ones that are very sort of floppy.
Perfect. So the best analogy that I can think of with that is people might have these big, huge fire hose sized airways, right? Like a hose for like a fire truck. But what happens when you take the water out of that hose of the fire truck? It collapses down to nothing, and you roll it back up, right?
Right.
So size matters when it comes to airway space, but it's not the only thing. So we can have people that have smaller airways that have no collapsibility that perform better at nighttime than people who have big airways who collapse. So it's even more in depth than what you're thinking. Like the whole growth thing is definitely a big, huge part of it, but how collapsible your airway is another part of it. And that has to do with the muscles in the back of your throat and in your nose. So let's go ahead and take a look at the CT scan. So Howard, this is one of the coolest things we can absolutely do from an imaging perspective, because when you walk into my office, I know what you look like from the outside. Now I know what you look like from the inside as well, and I'm going to be able to sort of dissect all of the structures that influence proper breathing. So this will be really neat. Go take me on a little tour here.
Holy cow.
Isn't that cool? So go a little bit further and pause. So this is your airway that Dana has measured for me. And we're going to get into that in just a second. But remember, like I said, the bones are sort of the structures of our bodies, right? So on the back side, we have your cervical spine. I can see your whole entire cervical spine right here. On the front side, I see your upper jaw and I see your lower jaw. In between those two bones is your airway. Okay? So the way that the cervical spine develops, the way that the jaws develop, can influence how big this airway is back here. So Dana, can you take me into the nose?
So in that photo where I have a little bit forward head, seems like that could pinch it. Right. So
well, actually, so the further back your head goes on your spine, probably the better orthopedically it is, but sometimes that can compress the airway. So a lot of people, when you find someone unconscious, what do?
You tilt their
head up. So by tilting their head up and forward, you can actually open up the airway, make it more passive. So a lot of people, we have this problem, like you probably read in the Nestor book, this problem where people are walking around like this all the time.
So they can breathe.
Just an easier way to breathe. And so what is this doing? That's causing all these structural problems. That's causing all these sort of functional impairments. And so just with improper breathing from childhood to adulthood, we can compensate and have all these problems that kind of arise. So anyway, let's jump into your nose. Okie dokie. So point of reference. Yeah, right? There you are. So point of reference, we're going to go into your face. So this is going to be your nose. You're going to see your lips pop up right here. You're going to see your chin pop up right here. So we're going to go into your face. Okay? So these are your nostrils. Keep going. That's your chin. You'll see some teeth pop up here pretty soon. All right, pause right there real quick. So the first thing I can see in your nose is these valves. So this is located about an inch inside your nose. And so one of the main points of obstruction inside someone's nose can be the entry point of air. And the entry point of air is the internal nasal valve. So the external nasal valve is something that I already looked at with that photo that I took. Your external nasal valves look fantastic. You can get air in because your nostrils allow that to happen. Yeah, I'll take this. And when air goes in about an inch, we see that your valves are a little bit more pinched shut. So you still have some opening here, but it kind of compresses right here in the middle. So that means air flowing in through your nose has to take different routes, has to take different sort of pathways to get to where it needs to. And that can be a first point of obstruction. So that can cause you, I know I have internal nasal valve collapse, so when I run, I typically have to start breathing through my nose or through my mouth unless I have my nose cones in, which really flex my internal nasal valve open.
Cottle's was effective.
And so that Cottle's maneuver, Dr. Cottle, that came up with this, he just basically said, if you can take your fingers and pull your face apart and open up your valves inside, and if that's better airflow, that means you have internal nasal valve collapse, which is consistent for you. You get more air in when you go like this and pull your valves open. So let's go ahead and into the middle part of the nose. This left side's very, very narrow. See how asymmetrical you are inside your nose? Everybody's asymmetrical a little bit, but oh boy, yeah, you do have a deviated septum. So pause right there real quick. So we're about midway into your nose, not even midway. We're kind of still at the premolars here as far as going into your face. We have a pretty deviated.
So as this is going like up.
In. Yep.
Like from the front to the.
We're like right here right now.
I see.
Cross-sectional, right there. So we can see your septum is starting to bow to one side and is starting to deviate, and there's not much airway space in here. So the black is the airway space. There's not much inside your nose. So your airway space is very limited. Keep going, Dana. Okay, pause right there. So you can see your septum is deviated probably 3 different times throughout. So again, this just creates a lot of turbulence inside your nose and creates more sort of tendency to breathe through your mouth when you're exercising or sleeping or whatever. And so this is what the nose should look like. So if you take a peek in here, see how straight that septum is? See those little bones on either side of the septum? One right there, one right there.
Yeah.
So those are what's called your turbinates. So your turbinates are represented right here on the image, and these are these little pieces that kind of look, like musical notes, right? And so all the black space is sort of your airway space. So your turbinates are rather large, your septum is rather deviated, and as far as the amount of airway space inside your nose, it's very limited. So from a structural perspective inside the nose, it's not ideal. So the other thing that I'm noticing here is, Dana, keep going right there. Beautiful. You have an extreme amount of bacteria that is pulled up in your left maxillary sinus, and he's got a little bit of pulling of bacteria in his frontal sinus as well. So do you feel sick or anything today, or do you feel well?
You're fine.
Yeah, so this is probably a chronic thing that's probably been going on for a really long time. As you can see, your turbinate here is so large, it's pushed the septum over. You don't really have a great communication from your sinuses to your nose to get this stuff out of there. So you've had a lot of bacteria pool over many years, and you probably have done sprays and things like that to try and get that out of there. But I think a lot of the structures and you not using your nose as effectively as you could has caused all this bacteria to kind of pull up. So that's what the sinus should look like. See how nice and clear that is?
Mm-hmm.
This one has this big, huge mass of bacteria. So we'll talk about how to get rid of that. Keep going. Good. Okay, let's go to the airway. All right, now the fun part. So can you delete that for me? Okay, cool. So like I said, you have your cervical spine, you have your upper lower jaw, and then you have the tube that you breathe with, right? So that tube should connect all the way up to your nose and then connects down to your lungs as well. So when I look at your tube, the amount of space that's in the back here is really not that bad. It's actually pretty decent, which surprises me because of how much lack of growth that you've had in your jaws. So if your jaws would have grown even further, bigger and downwards, this would be even bigger, which would be great. Now again, I wouldn't call yours a fire hose type of airway, but it is decent enough. I see people's airways who are, 1/5 of the size of this that have problems.
Mm-hmm.
So the nice thing about you is your airway makes me feel like we're going to have great success. So the people that have the really, really tiny airways, those are the people that we really talk about how big of a challenge it's going to be to get them to breathe through their nose.
Mm-hmm.
So the airway in the back here from an anterior posterior perspective looks good, but as you sort of can recall, the airway is not a two-dimensional thing. The airway is a three-dimensional thing. And so the amount of space that we have going from transverse to anterior posterior matters. So anterior posterior is not too bad. Transverse is where you kind of struggle, and that's because the jaws are so small and all that. So
transverse meaning left to right.
Yeah, exactly. Yep, from one side to the other side. So go ahead and let me see the joints. Okay, so that's the right jaw joint. Okay, doesn't look terrible. Left jaw joint. Okay, doesn't look terrible. Can you guys get out of there and go to the other dimension? Scroll through that for me. Good. Scroll through this one for me. Okay. So I'd say a little bit of wear and tear on the jaw joint. Nothing that's too severe. We always check people's jaw joints because the more you can't breathe, the more you grind your teeth, the more likely you are to start ruining your jaw joints and to start really causing structural problems within the joint. The good news is the bone looks pretty decent. Looks like you got a little bit of wear on your tires as far as the jaw joint goes from overuse, but nothing that we would say needs a replacement or anything like that. So I think we're in a good point here to try and make some decisions because I do feel like I understand your airway pretty comprehensively now. So remember, the two keys to breathing is, can we keep the size proper, and can we teach you how to breathe through that size easier? So really two concepts. We got to make it so you can breathe easier, and then we have to teach you how to breathe easier, right? It's two different things here that we're talking about. So as far as the size of your airway goes, you struggle from that left to right position, that transverse position. Has to do a lot with the fact that your orthodontist took those teeth out and squished everything into this really small space. Your tongue doesn't really have a place, home that it calls it consistent. Your tongue probably drops into the back of the airway, and like we saw with that pharyngometer is, your airway collapses when there's no air inside of it. So although it's big enough, it does collapse, and I think it's because of the influence of the tongue and the soft palate and the small jaws. So from an orthopedic structural position, I think doing what's called rapid palatal expansion, and I'm sure you heard about that in the James Nestor book, with maxillary skeletal assistance from an airway orthodontist would be a fantastic way to help you out. Now, I don't want to speak for them because I kind of look at myself with these situations as sort of the quarterback. I'll be able to come up with the playbook. I'll be able to come up with the play that I want to execute, and then we rely on all the people to do their jobs in order for this to sort of, and for the play to work out and to have that proper execution. So sometimes I can help people with the services that I can have. Sometimes I just send people on their way to get the services that they need from somebody else. So one of the people that we may want to consider using is an airway orthodontist, someone who's airway-centric, knows how to take your jaws and make them bigger, and she'll kind of go over that, and she was referenced in the book that you read by James Nestor Breathe. Her name is Mariana Evans, and I'll let her talk to you about a little bit more about this. She's right down the road. We're so fortunate, so lucky to have her. So what she'll talk about with you is potentially taking your upper jaw and increasing its size, and then doing orthodontics to be able to bring things forward. So if she can increase the size of your jaws.
So is that with like an operation?
So she does it a very specific way. So we don't really love when we have to do a surgical operation to split the jaw and get it to start moving. So if we can do it without surgically cutting the jaw, that's always how we prefer to do it. Now my wife is currently in the middle of this, and my wife has been so successful so far. Dr. Evans has got my wife's palate to split, and she's moving my wife's jaws like this. And it's like a 3 or 4 month process. So my wife's got her big jaws now. Now she's in the middle of orthodontics, bringing everything forward.
Okay.
So with that, I think that will address your structural problem. I think that's a fantastic way to address your structural problem. Now what you may notice is that Dr. Evans may create so much space in the jaws that the teeth will actually have a lot of space in between them, because you are missing, remember, 8 of your teeth. So there may be a time that comes where Dr. Evans has a conversation with you and says, hey Howard, we're going to create a lot of space in your jaws. Your teeth aren't going to fit together as much anymore. We may need to consider opening up some space and putting some new teeth in there with some implants. So that may be something that she goes over with you, but again, I don't want to speak for her when I say that, but she may want to consider opening up some spaces and getting some more teeth back in your head for you to use.
I'm kicking myself for not saving those.
I'm kicking yourself too. I'm kicking your orthodontist too. But we didn't know what we didn't know back then. We didn't know. We would have done the same thing if we were in that person's shoes. We just didn't know back then. So I think that's one way to address it. We've got to get rid of some of this nasal congestion that you have going on. We're definitely going to get you started on breathing therapy right away. I know you're already sort of familiar with that. We do have a breathing therapist here in my office. Her name is Lauren Reinholtz. She's a myofunctional therapist and a licensed Butico breathing practitioner. So she's fantastic. And she works with a lot of our patients, again, hitting that second core concept, making it easier for you to breathe. It's a wonder when you start learning how to use your nose properly, how much more efficient it works. The nose is a use it or lose it organ. You have to use it. You have to use it properly in order for it to work. And what we now know is that when we breathe through our nose, our airways actually get bigger. They dilate. We breathe through our mouth, they collapse more. And
that's the nitric oxide?
Yeah, the nitric oxide. You're exactly right. The cellular signaling molecule and gas that is important for literally every function in the body. If you don't have the oxygen get a nitric oxide to go down with it to the lungs, we make our gases off balance, we make our oxygen efficiency lower, and we make our bodies work a lot harder to do the same things and potentially not be able to do the same things. So nitric oxide is a key signaling molecule that helps with cellular respiration, but it also helps with dilation of the blood vessels as well. It allows our heart to work more efficiently. It allows our blood to flow more properly. It allows the oxygen to go to the places that it needs to go better. So nitric oxide is extremely important. So once we go through the breathing therapy, I think immediately you'll notice a big difference. But realize with the breathing therapy, we are limited. We're a little bit handcuffed in the fact that your nose is very deviated and off course a bit, and there's a lot of inflammation going on within the nose. And I know you're plant-based, which is fantastic. A lot of our patients that come in are on very westernized fast food diets, which cause a lot of inflammation, right? Fast food, sugars, glutens, dairy products, things like that. That all causes a lot of sort of inflammation for a lot of our patients. Good news is that that's not the case with you, so we've already gotten that kind of handled. So what we may want to do is, if we're going to sequence the treatment, we may want to have you see Dr. Evans to talk about expansion. Now remember, as you expand the jaws, the nose will be influenced. That septum that's really deviated right now could start to straighten itself out a bit if we get proper expansion. May a little bit, may not. But if it doesn't, then we may want to elicit the help of an airway-centric nose doctor, right? You would call him an ENT, right? But there's a lot of ENTs that specialize in different things. We would want to use an airway-centric nose doctor to be able to fix the septum, get the inflammation.
So this would be like a functional nose job?
Yeah, exactly. Not an external one, just an internal one like I had. I had mine about 2.5 years ago. Best decision I ever made.
deviated septum, hypertrophic turbinates, kind of look like yours a little bit. I got it all cleaned out, rotor-rooted, straightened up, and now I can breathe so much more efficiently at nighttime. I'm not grinding my teeth as much, and I have way, way deeper sleep. So that's something that we may want to elicit, but we have to follow the sequence of treatment here. So that's kind of the right way to treat you, Howard, if you want my opinion. I think that's the right sequence of treatment. Airway orthodontics for expansion, breathing therapy, potentially some myofunctional therapy going on with that. And myofunctional therapy, remember, is getting the patient to breathe through their nose, using their lips and their tongue properly, and having everything in the mouth be balanced, and also strengthen the muscles of the airway. Because remember, that breathing tube that I showed you in the back of your airway is all muscles. So what better person to do therapy on that than a myofunctional therapist who specializes in the muscles of the airway. So airway orthodontics, expansion, breathing, potentially some myofunctional therapy along the way. You're going to be learning in just a minute. And then we might want to think about using ENT if the structures are still not, if they're still handcuffing us to the point where we can't do anything more about it and we're still not at our goal.
Gotcha. What's the time frame for all that?
About 18 months. Yeah. Now it may be more, but it may be less. That's a general time frame. I know that's the time frame for my wife, who's kind of a little bit in your situation. And everybody's just a little bit different, but that all depends on the sequencing of how we progress through development. Some people develop very easily, like my wife. Her mid-palatal suture broke on the 3rd day. Some people it takes some weeks. Some people they have to do a little surgically assisted palatal expansion. So it all depends on how your body responds to treatment. And then that's kind of the best way to do this. Another way to do this is, we know you have sleep apnea. We know you stop breathing 20 times an hour on your back. We could take more of a conservative measure where we're managing your condition, and we use what's called a CPAP or an oral appliance. Those are kind of can I see an oral appliance? So I wanted to give you an introduction to an oral appliance. Not that I think it's your preferred route, but I think that this works very well for a lot of people. So potentially this could work for your back sleep apnea. Now remember, when you're trying to stay on your side, you're really fighting the forces of gravity that are pulling your jaw backwards and your tongue backwards. So when you're on your side, it's not going to happen as much, right? So that's the whole positional apnea thing that you have. The other thing that we could do is we could fabricate an appliance that goes into your upper jaw, upper teeth, and your lower teeth. And it'll be double appliance, right? So it'll snap into your upper teeth, it'll snap into your lower teeth, and this will prevent the collapse of your jaw and will try and prevent the collapse of your tongue. Now with these bands on the side here, I have the power to put you wherever I want at nighttime, which means I can put you forward, I can open you up, I can push you back, I can do whatever I think is going to be best for you. Now what Dana did with the pharyngometer was she showed me what position you're going to be most likely to have success with. So the good news is I don't have to guess. I know what's going to make you successful. So if we want to kind of take the conservative sort of, I don't want to call it a lazy approach, but more of a management approach and not fix the actual issues that you have going on and just sort of manage things, this is a fantastic alternative to CPAP.
Are they complementary? Like, so if we do this 18-month approach, am I still going to have 18 months of apneas or side sleeping?
Probably. Yeah, probably.
Would getting the appliance interfere with the other stuff?
It would, because these appliances are static. They're not functional, and they don't work with sort of, growing jaws. So there's nothing that, like, we would have to make an appliance every week, and probably that would stunt the growth of the jaws. So you are making a short-term sacrifice for a long-term gain, and I realize that's not ideal. So sometimes what we do with these people is we put them back on CPAP and just put them on a nasal CPAP and have the air start flowing through their airway a little bit better, and then eventually get you back off the CPAP if it's not tolerable. But if you can't wear a CPAP, then you can't wear it. And we just have to really focus on strengthening up the muscles with myofunctional therapy, breathing through the nose with breathing therapy, eating right, exercising, doing all these external things that can really influence the way that we perform at nighttime.
And we wouldn't start the nasal, the ENT procedure seems like it would be the quickest fix, but we don't do that first because it might change based on the palate.
Yeah, for sure. You got it. Remember, the roof of the mouth is the floor of the nose. So we don't want to affect the nose until we're done growing the jaw.
Okay.
But if you chose this, if you came to me today and you said, hey, Doc, I appreciate it. I don't want to go through orthopedic development. I just want to get a quick fix.
Right.
And when we went with this, I'd probably send you right to the ENT to have that septum corrected.
because
Okay.
we know we're not doing anything with development.
Mhm.
Does that make sense?
Yeah. So the ENT would improve my daytime breathing,
Yeah.
running and stuff like that.
Yeah, absolutely. I think you'd be way more successful if you had a better nose to work with. But
Mhm.
realize that if you just fix the septum, you're not increasing the volume. You're just making it easier,
Mhm. Right.
right? Whereas if you develop the jaws, you're going to increase the volume
Mhm.
that we have. You're going to potentially get bigger lung capacity. You're going to get easier airflow because of spacing.
Gotcha. I assume it's going to make me much more better looking.
I don't know about that. I mean, I think there's not much to gain there. I mean, you got the look already down.
Well, it's a world of masks, so no, it doesn't really matter.
That's right. That's right. So what are your questions about all that? Is this do the kind of the pathways seem clear to you, or do you have
Mhm.
questions?
I had a question about we were talking about the neuroma.
Mhm.
Like those tests you did with my arm indicate that that's not related?
It's not a structural problem that your
Gotcha.
central nervous system is responding to.
Mhm.
So I did that neurologic test that I did to you, only test your central nervous system. If you're not centrally sensitized by your injuries, you won't
Mhm.
show up on my test.
Mhm. Gotcha.
But if one of your injuries is stimulating a sympathetic response
Mhm.
from your central nervous system, that will show up, and it's not.
Okay.
So that's good.
Mhm. No, I think it's really clear explanation. It's fascinating to look at all those pictures, these things that I've lived with my whole life and have never seen before.
Yeah.
So,
Absolutely.
yeah, no, I'm cool.
Cool.
This has been amazing.
Awesome. So I don't want to put you on the spot, but what are you thinking? Are you thinking you're going to take this journey, or are you thinking?
Take a guess.
Okay.
I drove 6 hours. I didn't drive 6 hours for.
I love it. I love it.
Management.
Yeah, I love it. That's great. Cool. So the patients that want to be active participants in their care, those are the ones that are going to get better the fastest and the best. So I'm excited for you, man. And maybe I'm not the one to do any more treatment with you. In fact, I just want to oversee all of it. I think my breathing therapist and my myofunctional therapist will be a big influence on you. But I don't manage her. She does her own thing. She's kind of my boss too,
Okay.
She tells me when to do my job correctly. And I think with that, and you going to see an airway orthodontist like Dr. Evans, and world famous right down the street here is fantastic. But maybe we can find somebody for you who's even closer to you. It's whatever you want to do, but we can work with you to figure out.
I guess it would depend. It would depend if I need to see her every 2 weeks versus.
Yeah, you won't, but I'll. If you want to at least set up a consult with her, I mean, nobody person in the entire universe to evaluate you and your structures.
Awesome.
I can give her a call today.
Okay. Let's go for it.
Cool. Any other questions?
Nope.
Awesome. Was this helpful?
Unbelievably.
Yeah, good. So make sure you tell Karen that she needs to come in here for an exam for herself.
Okay. Well, if this video works, I'll tell everyone.
Sweet. Awesome. I love it. Awesome, man. So if you don't have any more questions, I'm gonna let the girls kind of get you all taken care of, get you settled up here, triage the Karen. Then you're gonna meet with Lauren today to do some maybe a little session of breathing, and go from there, man.
Awesome.
All right.
Thank you so much.
Yeah, I'm looking forward to helping you out. Take care.